Perfect. Thank you all so much. I really appreciate the invitation to be here with you today and really appreciate everything you all do for the community. It's super helpful. My name's Aaron. I'm a licensed clinical social worker and I work for Goodwin Living. You may be familiar, Goodwin Living has a couple of retirement communities in Falls Church and Alexandria. We also have a lot of home and community-based services too, including home health, hospice, home care, all sorts of things. So we have a lot of services that extend outside of our building as well. I came to this profession. I got my undergrad in sociology and I got my master's in social work with a concentration in social work with the elderly, mostly a medical-based social work training. And so I spend most of my days talking to individual people, talking to families about what is most important to them in their medical lives and how to make sure that those things are discussed, documented, and ultimately honored. It's a very complicated system whenever we're talking about the medical system. There are a lot of communication things that are sometimes challenges for us. And so today, what we're going to talk about is what advanced care planning is and talk a little bit about some of the medical decisions that you may or may not know that you have complete control over, how to actually think about those decisions. And once you've made a decision about those things, how to actually document that in the most practical and appropriate way so that your wishes have the best chance of being honored when you need to make those decisions. We are also going to talk a lot about code status today. It's probably not a new topic for anybody that's watching, but if it is, we're going to learn a lot about it today. Code status is really interesting. It's one of the few things in the medical field that really only has a yes or a no answer all the time. There's very little room for any sort of straying away from either yes, attempt resuscitation or no, do not attempt resuscitation. And so we're going to talk about how to come to that decision that feels best to you and how to document that. And then we're going to talk about how to document things both legally and medically today. There are some practical reasons that you may want to have things documented in both ways, and we're really going to dive into the documents that are most helpful for doing that exactly that. And so we talked a little bit about advanced care planning. It really is whether you have a chronic illness, which is generally the population that my team is working with, or if you are just kind of making decisions as you go along. Advanced care planning really does try and put the power back into your hands on what happens in your medical life and your medical journey. This could be as simple as, do you have a preferred hospital that you would want to go to if you need to go to the hospital, all the way through the more complicated things like intubation, artificial nutrition and hydration, code status, which we'll talk about. And so it really is kind of wrapping up all of these decisions that you're able to make and documenting them appropriately. So we're going to start with code status. As I said, you may be familiar with this. Even if you are, this is a good example and kind of a good litmus test on how to start thinking about some of these medical decisions. Like I said, there are really only two options for code status. It's either full code, which means that we would attempt resuscitation for you, or do not resuscitate, which means that we would not. There's really no wiggle room on that. It's really got to be a full code all the time or a do not resuscitate all the time, for a couple of really important reasons. As you can imagine, when we come to the decision of whether or not we are going to attempt resuscitation on someone, it is usually in a very emergent situation. Something traumatic has happened to somebody, and we need to know, are we immediately starting the act of CPR, or are we not going to do that? If you don't know, and if you haven't made a decision about code status proactively, one has actually already been made for you. There is a default code status for everybody, and it is full code. It is to attempt resuscitation. This is a little bit of a liability thing for medical providers to say, we are always going to attempt resuscitation unless we have explicit directions not to, because their goal is to sustain life and to make sure that we are at least attempting resuscitation for people if they get to that point. It's really important to know that there are a lot of things that can happen to you before you may need resuscitation. There are two things that have to happen before when we're discussing whether we're going to resuscitate somebody or not. Your heart and your lungs both have to have stopped. If either one of those systems is still going, then we are not really at the point of resuscitation yet. We're not at that decision. There are things that we can do for either of those systems if they stop, but if both of them stop, that is when we may consider to try and resuscitate somebody. The goal of resuscitation is to kind of artificially and manually restart both the heart and the lungs. And so if there's, like I said, if either one of those is still going, we're not yet talking about resuscitation. But for the purposes of just kind of an easier decision, a yes or a no, this is a good one to start with. The statistics for people, when we talk about resuscitation, it's hard to talk about them and not feel like we're trying to kind of push somebody one way or the other. It is really important for code status and for every other decision we talk about today to have all the information that you feel like you need in order to make a decision that you feel comfortable with. And so that's really why we talk about the statistics with code status. For people that are over 65 years old, regardless of any conditions you have, but just in general, if you're over 65 years old, for people that have resuscitation attempted, it's actually only successful for about 5 to 10% of people. So about 90 to 95% of people over the age of 65 who have resuscitation attempted for them, it will not be successful. I work with a lot of hospice staff, whether it's the chaplains, the nurses. When we're talking to people about code status, if your heart and your lungs have stopped, from a clinical and a medical perspective, you have passed away, right? If your heart is not beating and your lungs are not breathing, then you are no longer living. So the question really is, at the end of your life, when your heart and your lungs have stopped, is your preference for us to allow you a natural passing and not attempt to reverse those things? Or would you like us to attempt to resuscitate you and kind of artificially and manually restart those systems? And neither one of those is a wrong choice. The statistics can sometimes make it feel like, well, if I'm over 65 and there's a good chance that resuscitation is not going to be successful for me, then maybe I might think about not having that done. And that's a totally valid way to think about it. I just met with someone who's 101 last week. She wants to be a full code. She's in relatively good health. She is of sound mind. She can make her own decisions. And she said, the 5 to 10% chance, I'm willing to take that chance. And if I've already passed away and resuscitation doesn't resuscitate me, nothing will have really changed. And so her perspective is also valid. Whichever one of these feels a little bit more representative of how you feel, again, it's not a right or wrong answer. This is a personal preference. And we just want to make sure that you're making these decisions that feel right to you and documenting them appropriately. If you do not want to be resuscitated, if you don't want to have that attempted, because the default is to always resuscitate somebody, we have to have a special form or a medical order called a do not resuscitate order, which you're probably familiar with. Again, it's one of those funny things in the medical field. We're usually signing something that's consenting to a treatment, or yes, I'm consenting to this anesthesia or this planned procedure that I've talked about. This is one of those funny times where you have to sign something that says, do not do this thing to me. And it's just because the default is to always attempt. Now that order is one of the documents that we're going to talk about today. If you are familiar with it, it's often printed on kind of like a highlighter yellow sheet of paper. We want people to see this form. We want people to be able to recognize it as the do not resuscitate form. And there are some practical applications for this form that are really important to talk about too. One really important part about this form is that it is a medical order, so it needs to be signed by a medical provider. It needs to be signed by you as well, because you are the one saying, I understand both the risks and the benefits of attempted CPR, and I've decided I don't want that, and that's cool. That is why you would sign this form. You also need a provider, whether it's a physician, a nurse practitioner, a PA. Somebody has to put their medical signature on this order to really give it the weight that you need so that people don't actually attempt resuscitation. Now, a lot of times when it's depicted, say in a movie or on television, CPR looks pretty simple. It looks like a couple of good chest compressions, maybe some artificial breathing, and then the person is up and back again and in a similar condition to before the resuscitation was attempted. In real life, that's not exactly how it works. The actual mechanics of CPR absolutely involves those chest compressions, some artificial breathing. It may include a heart defibrillator. Like I said, we're trying to restart these systems, and for somebody that it does work for, you usually do not kind of pop back up in the exact condition that you were in before. What really happens if CPR is successful, let's say you're part of that 5 to 10%, you really need to go to the hospital and likely to the ICU. If the resuscitation restarts those symptoms, we don't know whether that's going to be a permanent restart or a temporary restart. So we really need to get you to the hospital and to the ICU to do some pretty intensive monitoring for those things. And if CPR is actually successful, most people actually end up in the ICU either on an intubation tube to have that breathing kind of artificially supported, or on some pretty intensive cardiac monitoring machines to make sure that once it's restarted, it's actually functioning well. The other thing to consider is that if CPR is successful for you, it doesn't necessarily fix whatever happened to get you to the point of needing CPR. So, whatever has happened to you physically or internally, although we've restarted those systems, it has not cured you of whatever got you to that point, which is another reason that the hospital is really the best place to be after a CPR, after a successful CPR. I talk with a lot of people, and sometimes it really is just playing it out. I've been talking about code status for a little bit now. There's really only two options, but there's a lot that goes into it. I talk to a lot of people who say, yeah, I would like to remain full code. If it doesn't work, no harm, no foul. But I don't want to go to the hospital in general. Regardless of CPR, I'm really trying to avoid the hospital. When you really play it through, and if that CPR is successful, you will go to the hospital. And so knowing kind of what the outcomes are on either side is really important. Most people who end up in the hospital after a successful CPR over 65 do not leave the hospital in a similar kind of baseline to how they were before. There's usually some sort of compromising of some sort of body system. It could be cognitive decline if there's been limited blood flow to the brain or oxygen flow to the brain. There could be some pretty significant physical decline if you've been in the hospital before and you've been laid up. Excuse me. If you've been laid up for a couple of days, sometimes it's not as easy to transfer from the bed to, the bathroom or to do your activities of daily living. So it is important just to kind of realize that although this is absolutely a valid decision that you can make, it may not be as simple as some of the depictions that we have kind of in the media. Um, Continuing, so let's say you decide you want to have a do not resuscitate order. Like I said, most primary care physicians and all hospitals have these forms. So if you don't want to have resuscitation attempted, they can give you that form. The form is also available on the Virginia Department of Health website. And when I finish yapping away, I will leave up my last slide, which has a lot of useful websites that you can find all the things that we're talking about today. But if you do have that form, it's really important to know what to do with that form, right? It doesn't do us a lot of good to have a do not resuscitate form that is signed by you and a physician that you don't know where it is, or it's locked in a safe somewhere and people can't really get to it. In real life, sorry, was there a question?
No, I think somebody just coughed.
Oh, no worries. Okay. So let's say something happens to you in your home and emergency services are called and your heart and your lungs have stopped. Emergency services are trained to look in two places in somebody's home for a do not resuscitate form. One is behind your front door, and the other is on your refrigerator. Those are the two places that they will always look. If they cannot find that form in either of those two places, they will immediately begin to attempt resuscitation for you. It's really important that and this kind of goes for all of the documents we'll talk about. It's important for you to know where these documents are for yourself. it's important for your healthcare providers to have copies of these documents. And it's important that your family or your support system that might be involved in helping you make healthcare decisions know where these documents are and ideally are part of these conversations that you're having while you're making these decisions. Now, things don't always happen in your home. There are things that happen out in the community. You could be grocery shopping, you could be out for a walk, and something happens to you. On the code status side of things, some people ask, I'll just get a tattoo that says DNR. In Virginia, that doesn't really fly, but there is another option that Virginia does participate in. It sounds a little funny to talk about, but it is kind of our solution for this. There is a Do Not Resuscitate jewelry program where you can submit your completed Do Not Resuscitate form to the Virginia Department of Health, and they will send you a piece of jewelry. It's either a necklace or a bracelet that if you would like, you can wear it on your neck or your wrist, and emergency services will always look in those two places as well if they are responding to somebody that is not in their home. So it's just another option for people. If Do Not Resuscitate, if you feel really strongly about it, having the form is a really good first step, but you might want to consider, posting that form in your house somewhere that's visible and potentially having some of this jewelry to make sure that if something happens outside of your home, that resuscitation, again, we're trying to give ourselves the best shot of our wishes being honored. It might sound a little crazy to wear a piece of jewelry that says do not resuscitate, but if you feel that strongly about it and you really don't want that to happen, it's the closest we can get to making sure that that's communicated anywhere that you are. Any questions about code status so far? Like I said, it seems more complicated than just the yes or the no.
Well, we've got a comment here that said Virginia Department of Health says they do not sell the DDNR jewelry themselves, but provide a link to a vendor. And
Yes.
Sue's posted that link. So
Yes,
anybody
thank
that's
you. And that
curious
link will
can.
be, yeah, that link will be on the last slide as well. Thank you for clarifying that,
Okay.
though. Yeah, it's not directly through the Department of Health. Any other questions or comments before we move on from code status?
We had one, but you've already answered it. We've got another one. What happens if a person has a do not resuscitate order but changes their mind?
Yeah, that's a great question. Basically, a lot of people will advise that you just kind of destroy that piece of paper. I think it's a little bit more, you could be a little bit more thorough than that. Because this is a medical order, the order doesn't kind of go away if you destroy that piece of paper, right? A lot of times this order is electronically entered in your medical record, whether that be with your primary care physician. A hospital will kind of put a blanket code status order in for you if they have that on file. Usually what you have to do, and this again goes for more than just the DNR order, you need to write something out that says that you are revoking the do not resuscitate order. You need to have that either witnessed by two people or you can have it notarized. In Virginia, either one of those will do. Basically, what I would recommend is writing something out like that, having it either witnessed by two people or notarized, and then attaching it to the original document to say, I know I filled this form out on this date. However, on this date, I've changed my mind and I would like to revoke my do not resuscitate status as of this date. They really should stay together because as you're providing updates to your primary care physician, consulting physicians, hospitals, you want to make sure that those things stay together so that they know that although they may have the order that's on file, you would like to have it revoked as of X date.
Another question, are copies of the original DNR sufficient, or do they all have to be, individually signed?
No, the copies are perfect. We actually encourage people when I complete a do not resuscitate form with somebody, I will make copies, usually on the yellow paper, and give them about 5 copies and say, hey, make sure that your medical power of attorney has this copy. Feel free to give a copy to any of your providers. Similarly, electronic copies are also valid. As long as it has that physician's signature on it, it can be a copy or it can be an electronic copy.
Okay. Can you put your DNR form on your phone?
Yeah. Yeah, that would kind of count as a an electronic copy. We encourage people to have copies on their phone, and everybody mostly carries a phone around that has the capability to have pictures on it. It's another kind of, new age way of saying, hey, make sure that people have a physical copy, but also like have them take a picture of it on their phone. If your medical power of attorney, gets to your house at the same time as emergency services, and for whatever reason, your do not resuscitate form is not on display, they can show them that signed copy from their phone, and that would work just in the same way.
Okay. Liz followed up with somebody changing her mind uh, with a case of somebody who said, "Don't give up on me," before lapsing into a coma. So, what happens in that case when they haven't had the chance to sign the revocation?
Yeah, that's actually a really good question, and it's a kind of perfect segue to what we're going to move on to as well. So, like we said, the do not resuscitate really is a medical form. It's a medical order. Advanced directives, you're probably familiar with as well, and hopefully people have them filled out. An advance directive is not necessarily a medical form, but it is a legal form. And in my experience, there are two really practical things that an advance directive can do. The first is to appoint medical decision makers for you if you're unable to make your own medical decisions, and we'll talk about what that looks like. And then the living will section of the advance directive is a really great opportunity for you to dictate and really spell out, these are the things that I know I would want. These are the things that I know I would not want. And it serves as a little bit of a guide to anyone that might be making decisions for you. Hopefully and ideally, I preach about this all the time. We should be having these conversations with people, with your medical decision makers, with your physicians, if possible, so that in real time, hopefully you're not being approached with a decision that you've not at least discussed in some way or that isn't listed on your advance directive. It is so much more difficult to make a decision about something you think someone would want as opposed to having these conversations ahead of time and really advanced care planning to say, yeah, although it's not explicitly written in the advance directive, or although, we haven't, we've had this conversation before, um, it's so much easier to say, we've talked about it, and I know that this is what they would want at this point in their life or not. It obviously can't cover every single medical situation, but the living will section really does give you an opportunity to put down your thoughts on things exactly like we're talking about, like resuscitation status, mechanical ventilation, artificial nutrition and hydration. We'll talk about kind of hospitalizations and hospice as well. A spoiler alert, we're going to talk about another medical form a little later too. A lot of the decisions that we're talking about can be addressed in both the advanced directive, the legal document, and a medical order or a medical form. These things should always kind of go together, right? There shouldn't be conflicting information on these. It sounds a little nitpicky to have two different documents that say the same thing. However, the practicality of each document is a little bit different, which is why we encourage people to have both of them and make sure that they say the same thing. For the advanced directive, like I said, it's really important to have things written down. In an emergency situation, it can be really hard to remember what somebody talked about or to remember a conversation that you had maybe 5, 10 years ago. If it's written down in the living will portion of the advanced directive, it's a good guide, it's a good reference to say, oh, okay, I can't remember exactly right now, but I'm going to skim through the advanced directive. It says something about code status here. This is the decision that we're going with. It's much more easy to carry out a decision that you've already talked about than to try and make a decision that you haven't talked about. Which kind of leads to the question, like, how do you know who to pick for your medical power of attorney? Um, Most people assume that it has to be somebody in your family, somebody that you're related to, which it does not have to be. You can pick anybody that you'd like. What we generally encourage people to think about is, will this person, A, be accessible and reliably accessible because emergencies can happen at any time? And so is this someone that you can pretty much rely on to pick up the phone should you need them to? And is this someone that even if their personal medical preferences don't align with what your medical preferences are, do you think they would still be able to carry out your preferences if you're not able to speak for yourself? Some people find that really difficult. Some people don't really have a hard time with that. They say, although I wouldn't want CPR, I know that this person would. And so I'm just going to make sure that that happens for this person. In Virginia, you can list more than one person as your medical power of attorney. There's really no limit on how many people you can list, but there are some kind of practical things to consider. I've seen some advanced directive documents that say, I have 6 children and I'm listing all 6 of my children as co-medical powers of attorney, and they all have to agree before any decision may be made. As you can imagine, it would probably be a difficult task just to even get all 6 of those people on the telephone, let alone for them to all agree on the same decision. Our recommendation is typically to list people in sequential order and say, this is my primary medical power of attorney. The legal language typically says if this person is unwilling or unable to serve in this capacity, you can move down to my secondary power of attorney, my tertiary. You can list them all in rank order, and you can list all 6 of those kids if you'd like, but making sure that there's an actual order is just a more practical thing in an emergency situation. It's really important to know that decision-making power only goes to your medical powers of attorney if you are unable to make your own decisions. And there has to be some backup to that. We can't just decide willy-nilly that this person is not able to make their own medical decisions. There are some really kind of obvious signs that someone's not able to make their own decisions. If you are unconscious, if you are under anesthesia, those are things where we can say that person cannot currently make their own decisions. On a broader scale, if there is a question of maybe cognitive decline, if somebody has a cognitive diagnosis, just because someone has, let's say, a diagnosis of dementia, doesn't mean that they immediately cannot make their own medical decisions. There is a process called a capacity determination in Virginia that basically says to physicians, if there's a question on whether somebody has capacity to make their own decisions, they should be interviewed by 2 physicians, hopefully physicians that they know. And those physicians will make determinations on whether or not that person is able to make their own decisions. Ideally, those 2 physicians will agree. If they don't, and we have one that says yes and one that says no, we kind of go to a third physician who kind of makes that determination. In Virginia, this needs to be documented by the physicians. They will say, this is the date that I interviewed this person, this is what I found, and this is my determination on their capacity. It's not a blanket determination, though. So in Virginia, you have to be reassessed for medical capacity at least every 6 months. And that is really just at least. You can be assessed for this at any time. A lot of primary care physicians, and a lot of, I'd say, consulting physicians, especially neurologists, are no strangers to making these capacity determinations or doing redeterminations at least every 6 months. Just kind of anecdotally for Goodwin Living, we have some memory support neighborhoods for people that have advanced cognitive decline. We do this every 6 months. They are still assessed for their capacity determination because it is a Virginia law. The likelihood that people are going to regain decision-making capacity with advanced cognitive decline is pretty low. But the law is in place for some of those other situations where if somebody comes out of anesthesia but is still kind of a little bit foggy, or if we know that they're going to be unconscious for whatever reason, there are those kind of temporary situations where someone wouldn't make their own medical decisions. And so we need to know who we're actually calling to help with those decisions in those situations. I always share this website. I think it's really helpful, and you can find advanced directive templates in a lot of places. The AARP website is another place you can find them. Caringinfo.org I have found especially helpful, just because, we're in Virginia, DC and Maryland are very close. Caringinfo.org has a little drop down, and you can pick a template for any state or municipality that you live in, that will spit out kind of a blanket advanced directive that you can fill in your primary and secondary powers of attorney. You can fill in your living will section and say, this is what I want, this is what I would not want. And so you can make changes to that at any time. You do not need a lawyer in Virginia to complete an advanced directive. Lawyers would be happy to prepare them for you. It often comes with a fee, with whatever lawyer fee is associated with that. And so, if you're doing all of your documents, let's say you're doing your regular will or some trusts and you're already meeting with a lawyer and you want to do your advance directive, they can absolutely prepare these for you. However, like I said, you really only need two witnesses in Virginia to make this document legal. So let's say you print out something from caringinfo.org, you fill it out in a way that feels representative to you. You need to make sure that you have two people, two friends, two neighbors to be present while you're signing this. And then they will sign as witnesses. As soon as you have those two witness signatures on there, it is a legal document in Virginia. Um, you can make changes really at any time because you don't need a lawyer. You can do these changes at any time, and you really should make these changes. We always advise people, after a hospitalization, if you are feeling differently about what your advance directive said before you went in, you should maybe take a look at making changes to that. If you've had a severe hospitalization, if you have a new diagnosis, if you have a diagnosis that has resolved and you're actually feeling better than when you made your advance directive, any kind of health change is a good it's a good time to do a pulse check with your documentation to say, if whether I'm feeling better, worse, or pretty much the same, is my advance directive still reflective of what I would want or what I would not want? And because you can do this at any time, we encourage people, realistically, a lot of people, when I ask, when's the last time you've looked at your advance directive? We'll say probably 5 or 10 years ago. I always advise people every couple of years, maybe every 2 to 3 years, if you're pretty healthy, um, you know, at least take a look at it. Just make sure it still says the things that you want it to say. A lot of these things, as people age and maybe as chronic illness progresses, or if you have a new diagnosis, you may feel differently about some of these things. So you can make these changes really at any time. Now, in the advance directive and the living will, you can put your preferences on code status. It's really important. This is a really common misconception too. Someone can have an advance directive which dictates that they would like a do not resuscitate form completed. You still need that medical form completed. The advice or kind of the guidance in the advance directive is not enough to actually make sure that that do not resuscitate order, it doesn't make that order kind of unnecessary. You still do need that order. But if somebody doesn't know and somebody doesn't know, your preferences on that or don't know that you already have that completed, that can be, again, it's a reference or a guide for your medical powers of attorney to say, actually, they've made a decision on this. Now I just need to logistically get this signed for them. Artificial nutrition and hydration is really interesting too, and they're actually very different. Artificial hydration could be as simple as just some IV fluids, and a lot of people have had those. If you've been in the hospital, they'll usually give you some IV fluids just to make sure that you're not dehydrated. That can feel very different than artificial nutrition, which could be through tube feeding that either goes through your nose directly into your stomach. There are many routes for that. There's usually a type of surgical placement for artificial nutrition. And so some people feel differently about both of those things against each other. Some people will feel like, yeah, I'd be totally open to IV fluids, but I definitely wouldn't want like a permanent feeding tube if I'm not able to take in food by mouth. I might not want to do that. Some of these things too, like these are options for medical decisions that you can be thinking about. Most people are generally not going to be on a feeding tube at some point in their life, but if you have a really strong idea that if it was ever suggested, you wouldn't want that, it's some guidance that you could put in into your advance directive. We'll talk about kind of the permanency versus a trial period too when we get to the next medical form we're going to talk about. Um, Level of preferred medical intervention is a really kind of broad thing to document, but it can be really helpful in guiding what medical treatments you receive or don't receive. I always talk about the ones on either end of the spectrum first because they're pretty easy to conceptualize. Full interventions means I want everything. Anything that's available to me, I'm willing to try. I'm open to CPR. I want to be a full code. I would be okay going not only to the hospital, but to the ICU, any sort of machinery. I'm open to that. There are some people that feel that way, and that's totally fine. There are people on the other end of the spectrum who say, I'm really looking just for comfort. I'm not looking to do anything. heroic. I'm not looking to do any curative or restorative measures. I would really like my pain managed, all of my symptoms managed, and I'm really trying to avoid the hospital. It's something that usually goes along with comfort measures. Limited additional interventions is kind of a catch-all, and honestly, a lot of people fall into this category. They may not want absolutely everything, but they may not be ready for only comfort measures. Limited additional interventions basically means I'm open to seeing what my options are. You know, if it's something that's associated with a chronic illness I have, or if it's a new diagnosis that comes up, I want to talk to my doctors that are involved in that care, figure out what the options are, and make a decision from there. A really easy example of this is, let's say somebody has a new diagnosis of cancer. Depends on what stage it is. You may have a lot of options for either surgery, chemotherapy, radiation. That's the sort of thing that's probably a little bit more difficult to make a decision on before you actually have that diagnosis. So limited additional interventions just kind of leaves you open to the options that are available. Comfort measures, if that is something that you're really looking for, denoting that in your advanced directives and on the other medical form that we'll talk about is really helpful from a practical standpoint to say, okay, we know we're not trying to go to the hospital. We know that we're trying to manage pain and comfort. Instead of talking about restorative therapy or chemotherapy or going to the hospital, maybe we're talking about palliative care or hospice. Denoting these things can help guide you to the resources that make the most sense for what your goals are. And similarly, full interventions just means you've denoted that we kind of have the go ahead to do anything and everything for you. Hospitalizations and hospice, there's never a guarantee of what hospital you will go to, especially if you're being transported by emergency services. You can denote, though, in your advance directive and on some medical forms, if you have a preferred hospital, if you have a hospital that, if you have Kaiser and you need to go to a certain hospital that takes your insurance, you can always denote that. You can always say that if you are conscious to emergency services, I'd like to go to this hospital. Depending on what is kind of the reason for your hospital transport, they may say, sure, we have the time to do that. That's the closest one, or that has the trauma unit that we're looking for. If not, they always reserve the right to take you to either the closest emergency room, the one with the least amount of wait time, or in a trauma situation to a trauma hospital. But you can let people know your preferred hospital. Hospice as well, for people that have had previous experience with hospice or just have a good understanding of what hospice is. Some people will write in their advanced directives, if I'm ever eligible for hospice, if two physicians both kind of declare that the way my diagnosis is going, my prognosis is about 6 months or less. Some people will write in, I would like to be admitted to hospice when I'm eligible, if I'm ever eligible at that point. It's something important to include in advanced directives, because it just lets us know that you've at least thought about this as an option. You're familiar with the resource, and if you're ever eligible for that resource, that's something that you would like to activate. Hospice is an insurance benefit, typically through Medicare Part A. And so just denoting somewhere that you're open to exploring that when the time comes can have some pretty good resource implications for you so that hospice can get involved as quickly as possible.
Aaron, we had a request for you to maybe slow down a little or take some pauses so that
Sure.
people that are trying to take notes can keep up.
Yeah, no problem. And if it's helpful to you all, I'm happy to share this PowerPoint. You're welcome to send it out to anybody that's on the call or anybody that you would like. Um, but
Yeah, that
yes,
would be good.
yeah, no problem. Now, advanced directives, similar to the do not resuscitate form, they're really only useful when they're completed appropriately and when they're accessible. So, like we said with the DNR form, making sure that the people listed as your medical powers of attorney actually have copies of this advanced directive is really helpful. We encourage people to send these to their medical providers, to their primary care physicians, to their hospitals, to any estate lawyers that you might have. Making sure that this is as accessible as possible, again, gives you the best chance of having your wishes honored. All the things that we've talked about in advanced directives, they're really helpful as a guide for your powers of attorney. But again, because the advanced directive is a legal form, the advanced directives don't actually hold a ton of weight medically. We've come up with a little bit of a solution for that to actually enter everything that is in your advanced directive as your preferences as medical orders. And if you're familiar with the PULSed form, that's exactly how you accomplish this. The PULSE form stands for Physician's Orders for Life-Sustaining Treatment. Virginia adopted this form about 3 or 4 years ago. Before that, you may be familiar with a form called the POST form. In Maryland, it's called the MOLST form. We had all of these different forms that really were trying to accomplish the same thing, floating around in lots of different states. A lot of states are opting for this pulse form, which is the national form and is kind of recognized all throughout the United States. And it really is just to hopefully get everybody on the same page and using the same form. Similar to the do not resuscitate form, this is a medical form, and this needs to be signed by a medical provider who knows you. And I will put up the link at the on the last slide too, where you can go to the Post website. You can download a copy of this form. Most primary care physicians and hospitals have this form in addition to the do not resuscitate form as well, for that exact reason, to make sure that if you have decisions about the things that we've talked about so far, that those actually become medical orders as well. The pulse form and the do not resuscitate form, because they are medical orders, they really do carry the medical weight that you need for your primary care physician or in a hospital setting. And the pulse form, actually, the first section of the pulse form is about code status. It basically says, yes, attempt resuscitation, or no, do not attempt resuscitation. Everything after that there's no surprise here. It's all of the things that we just talked about: artificial nutrition and hydration, your preferred level of medical intervention, if you have preferences about hospitalizations and hospice. This is the form where you can really dictate that out really clearly and have that physician sign the form. Um, if you look at the form, there are three main sections. There's a section C that is basically a write-in section where I typically, when I'm talking to people about this form, when we're talking about hospitalizations and hospice, section C is a really good place to hand write in some of your preferences on your preferred hospital, admit to hospice services if you're eligible. Don't send me to the hospital ever. We call that a do not transport order. You can put that in too. It's not kind of written into the general form, but it is something that you can write in that section C. And so those are the things that we're generally talking about with the pulse form. Again, we want people to know that this form is completed. We want people to have access to this form. And so making sure that everybody that needs to have a copy of this has a copy of it is really important. On a practical standpoint, these forms are really useful in the hospital because, again, like I said, if let's say you end up in the hospital, but you have comfort measures selected on your post form, we already know, the hospital staff will already know that we are not going to put you on an intubation machine because that is not your medical goal. Your goal is to have your comfort maximized, and you are not looking for any sort of heroic measures. And so it could avoid an ICU trip that you don't want just by having this form completed. Similarly, instead of waiting for consent to put somebody in an intubation tube, if somebody has full interventions listed on their post form, we can go ahead because a doctor has already signed off on that. It is a medical order that we are doing all of the interventions available. We can get someone into that ICU room as quickly as possible and intubated as quickly as possible, and hopefully have a better outcome from that.
I
So
have a
having these,
question here. Um,
yeah.
are the post form and advanced directives only acted on if you can't speak for yourself?
Um, yes and no. On the advanced directive side, decision-making power only goes into effect if you can't make your own decisions. I work with a lot of people who have post forms completed. Oftentimes people are completely conscious when they're being transferred to the hospital. They will bring their post form with them, or we will send it with them, and they can continue to make their medical decisions. But as long as their post form is completed in a way that feels representative of their wishes, it's really just a good medical backup. You don't have to be unconscious or unable to make your own medical decisions for your pulse form to be used. However, if you are not able to make your own medical decisions, it serves as just in the same way that the advanced directive serves as a legal reference and a legal guide of what you would and wouldn't want. The post form is more practically used in a medical setting like a hospital to say these are directions and guidance on medical care that this person has made when they were able to make those decisions, even if that person is unconscious, under anesthesia, in a coma. We actually already have all of their wishes listed out on this form. It gives us some more clearer guidance to do things a little bit more quickly.
So what happens if somebody says on their post form that they don't want to go to the hospital, but the family or wherever they're living says, well, we can't keep this person at home in the condition they're in?
Mhm. Yeah, it's a great question. We talked briefly about the do not transport order. When I'm talking to people about that order specifically, I usually add the verbiage, do not transport without either the resident or the medical power of attorney's permission. So it doesn't mean don't ever transport me to the hospital, but what it means is instead of immediately transporting someone when a medical provider or a nurse or somebody says, hey, we think this person needs to go, it kind of puts a pause on that happening automatically to say, well, let's actually put this back in the hands of the person that we're talking about. And if they are able to make their own decisions, it gives you the time and the information to say, why do you want to send me to the hospital? What might they be able to do for me there? And is there anything that we could try before going to the hospital so that we could potentially avoid that hospitalization? In a similar way, if somebody is unable to make their own medical decisions, that decision-making power does ultimately go to the medical power of attorney. And even if there is and we write the order in that way intentionally so that it does leave you the option to go to the hospital. There are some reasons, people with, let's say, COPD, a chronic lung illness, a symptom of that is likely going to be shortness of breath. Most times, if you tell a nurse or a physician or 911 that you're feeling short of breath, they will want to send you to the hospital. If you know that shortness of breath is associated with something that you have and you don't want to go to the hospital every time because it's likely not going to change the outcome of your COPD, you can put something in like a do not transport that says, instead of sending me to the hospital every time I'm short of breath, even though I know they can't do anything for my chronic illness, can I just make sure that I have oxygen set up in my home so that I can put that on if I'm feeling short of breath? Can we make sure that I have a nebulizer treatment if I'm feeling short of breath? Do I have medication for the anxiety that I feel when I'm not able to breathe appropriately? It really opens up a discussion about the things that we can do before transporting someone to the hospital so that it no longer becomes the default. However, in a different situation, let's say the same person with COPD falls and we think they might have broken their hip. That's a very different situation, which we probably can't manage your pain with a broken hip in your home. We probably can't even really appropriately diagnose the broken hip in your home. The hospital may be the place that you want to go to have that evaluated and treated, which is why we want to leave the option open. It gives you more of the power to say, in these situations, I would consider going to the hospital. In these other situations, I probably wouldn't want to go. And I'd like to explore if there's anything that we could do before going to the hospital. Whenever somebody talks to me about never wanting to go to the hospital, it's usually a natural time to talk about things like palliative care and hospice to say, if there are treatments or interventions that we can bring to you where you live, localized in your home, if there are things that we can do to help you with those things and avoid hospitalizations because we know the course of your illness is probably not going to change from going to the hospital, that's a good resource. Those are good resources to explore. Palliative care is really all about symptom management, and so they may be helpful in managing any symptoms that might be associated with your illness. And hospice, because it's an insurance benefit and you do have to qualify. When someone's saying to me, I don't want to go to the hospital ever, it might be a good idea just to do an eligibility assessment for hospice to see if you qualify to say, okay, we understand your goal is to stay in your home, to not do anything heroic, to not go to the hospital. If that is your goal and you actually qualify for hospice, it can bring in a lot of additional support, both medical and social, into your home and help you kind of maintain your symptom management, your pain management, and your comfort from the comfort of your own home without having to go to the hospital to access it. I believe that is my last information slide. I'm going to leave this one up. It's got information about the advanced directives where you can print those out, about the Do Not Resuscitate program, which has the fact sheet, some jewelry information, the post form. And then the post form, we have our own Virginia Post website as well. One thing I didn't mention about the post form is if you have one completed, having copies provided to everyone that needs it is a great idea. You can also actually upload your completed post form to the Virginia Post website. It becomes portable in that way and accessible for any provider in the United States that's providing you care. They have access to this registry where, let's say, you filled it out in Virginia, but you happen to be on vacation in North Carolina and you end up in the hospital. A physician or an emergency room staff member can actually look and see, does this person have a pulse form from anywhere in the United States, and does that guide us in the treatment that we're going to provide?
Okay, we got somebody asking if you could restate the difference between an advanced directive and the post form.
Yeah, of course. The advance directive is the legal form, and the most practical thing about the advance directive is it names your medical powers of attorney so that if you're not able to make your own decisions, we know who we're calling. It also gives some guidance on your medical preferences, but because it's a legal form, it's not as practically useful in a healthcare setting. So you can have all the information about the decisions about what you would want or what you would not want in your advance directive. If you do have a good, thorough advance directive, we would encourage that you also put the same preferences in the version of the Pulse form, which is more practically used in a medical setting. Because it's a physician's order that is signed by a doctor or another provider, it actually carries a lot more weight to have a Pulse form, even if it's the same information as your advance directive. Doctors are a lot more familiar with the Pulse form. They are using the post form in ways to kind of guide your care in a way that the advanced directives are not as useful for. In general, advanced directives are it's a much longer document, which is not a fault of the document. We really want it to be as thorough as possible, and it serves as a good reference for people that are helping you make decisions. The post form is really a medical thing that a physician can glance at and say, we know this person's code status. We know that this person is open to hospice when they're eligible, or whatever you have on the post form. It's a lot more practical to use in like a hospital setting or in a physician setting. They should say the same things. We don't want advanced directives and post forms that are kind of conflicting with each other, but we just want it to say the same thing. Advanced directive, like I said, more of a reference for your medical decision makers, and the pulse form is more practically used if you're a physician or a hospital staff member.
Can you give medical power of attorney to people who don't reside in Virginia?
Yes, and you can give medical power of attorney to people that don't reside in the country or the continental US as long as they are available and willing to serve in that capacity. It is totally legal. The one kind of anecdotal thing I'll mention is the time change can sometimes be a challenge. So if someone is 12 hours time difference and something happens to you during the day, is the likelihood of that person picking up the phone in the middle of the night the same? Hard to tell. But just time change and just kind of physical proximity. Time change is important to think about. You don't have to be physically near the person to serve as their medical power of attorney. I will say too, for people that don't have an advance directive completed, Virginia is a next of kin state. So if you haven't executed your own advance directive, you can look it up on Virginia's website too. It will list out kind of the rank order of people that will automatically be consulted as medical power of attorney, if you don't have someone named already. So it usually goes, spouse, parent if they're still living, child, sibling. I'm not exactly sure how the order goes, but it will list all of those people. So even if you don't have an advance directive and something happens to you and you're not able to make your own decisions, there is kind of a process to contact people in that kind of rank order to say, hey, this person is in need of medical assistance. They don't have an advance directive. Are you willing to serve in that capacity? And if no, they just kind of go down the list from there.
All right. Well, it's exactly 11 o'clock.
We
So
did good.
if we've got time for one last question, if anybody's got something, and I noticed that several people have posted some useful links in the chat. So I will leave that up for a while for anybody that wants
Great.
to copy those down. All right. Well, sounds like
Excuse me, can one of you also email a PowerPoint of this presentation?
yeah, if Aaron sends it to me, I will send it to the ANV office. And so anybody that wants it can call them and ask them to send it to you.
Oh, so I have to manually call. I mean, you cannot just blast it to all of us participants.
No, I don't have everybody's email address. There's no prior registration. So,
Gary, this really
yes.
is the kind of information that almost everyone in A and V would be interested in having. And I wonder if it would be worth putting up a web page with this information, the links that have been shared in the chat, the PowerPoint that Aaron has given us, the the handouts that Noel says he is going to be sending, all of that, it seems like it should be available 24/7, not with people calling the office and knowing to call the office. Could we look into that?
Yeah.
Great, thank you.
Hmm. All right. Well, got a number of comments here about great presentation, packed with lots of useful information. Thanks for giving us our homework.
Yeah. It's not always the most pleasant thing to talk about, death and dying and hospice and all these sorts of things. It is really good to have these conversations in advance of an emergency situation. And hopefully some of this is a good kind of segue into having those conversations. I always encourage people to, even if you don't complete the Pulse form, even just printing it out and using it as a conversation guide to start these conversations around code status and your preferred level of medical intervention. It's sometimes a good little reference just to start having some of these conversations that, frankly, some families do not love having.
Right. And now
Gary,
oh, I was gonna
Gary, I just want to remind everybody that this is posted to the YouTube channel. So if you want to go back and listen again, or if you missed something or want to see the web links on it, you can always go to the YouTube channel and you'll find it there.
Yeah. So, and
That's
that
a
should
good
be up in
point,
a day or
Karen.
two.
Can I jump in really quick? Hi, everyone. It's Noelle.
Hey,
Nice to see
Noel.
you all. So I know this is super complicated, and I mentioned in the chat that Erin and I put together some handouts and a blog post about this for National Healthcare Decisions Day, and I can send all of that over to the office. And I love Sue's suggestion. It could be you all can feel free to um, redo it and put it on the website under the resources link. So that it's always there for people, and then maybe a mention of it could go out in the next newsletter or something. But there's so much information, and we did try to package it really succinctly, so I'll share that with the office.
Okay, great. Anybody else? All right. Well, I'm going to stop the recording.